Meanwhile, I am Narendra and I am working as additional professor of faculty in pediatrics, looking pediatric rheumatology at All India Institute of Medical Sciences, New Delhi, India. And it is the apex public funded hospital in our country. So I will be sharing our experience of systemic GIA and MAS for this meeting. Can someone help me with the next slide, please? Yeah. So this is a brief database of our patients' overall GIA, and this is broadly the catchment area. We are somewhere here. I mean, if I can use a pointer. Yes, this is Delhi, and this is the catchment area of the India where the patient comes to us. And if we look, around 1,000 patients of GIA are there over the last 10 years or so. And in that, for today's meeting, the systemic GIA, we have around 176 patients. Something has happened, I don't know. So 176 patients, and the mean age is around 7 years, and majority of them are boys. And the point that I want to highlight is the mean delay in diagnosis, which is around 18.5 months. And this is again because many of these patients keep on lingering with the diagnosis of infections and then keep on getting tons of antibiotics given their high neutrophilic leukocytosis kind of stuff. Sorry, I'm not getting comfortable with this. Yes. So someone was asking me what drugs, particularly biologics, are available with us. So this is a different story where we have covered, we are just analyzing this data of 115 patients who are on biologics of GIA. In that, for the area of interest for this house is the systemic onset GIA, where 35 patients of systemic GIA are on interleukin 6 blocker, that is tocilizumab, and that's the only drug that is available with us. And among 35 patients systemic GIA, 4 had macrophage activation syndrome at the presentation. So of note, most important concern while using biologics in a setting is the recurrence or the reactivation of infections. And the most notorious one is the tuberculosis, which is mainly with anti-TNF, but not with the tocilizumab. But tocilizumab often causes adverse reactions and infections, not tuberculosis, but other sort of infections. So we look at the predictors of time to the MAS. The presence of MAS is a bad predictor in terms of achieving remission. Again, time to remission and flare after stopping is more those who are having delayed time to remission. And the adverse event among the drugs, the use of tocilizumab, and by adverse event includes infections and infusion site reactions, which is more common with tocilizumab. Coming to the data of macrophage activation syndrome, so this is again a retrospective chart of 2018 to March 23, where we have 39 children with 49 episodes of MAS, and majority of them are systemic onset GIA, more than 51%. Others are lupus, MCTD, JDM, and Kawasaki disease. And the key observations again are similar to what we see across the globe, and they include fever, CNS manifestations like confusion, and at times irritability or seizures in patients with this. And this is the highlighting, and a bit painful scenario is the mortality is around 30% in children with macrophage activation syndrome. Out of 39 children, the mortality was 30%. So how do we manage the children? Though we have reviewed, written a review article in Indian Pediatrics to increase an awareness about this particular entity. And what we are doing is to begin with, we are starting with IV methylprednisolone and IVIG as a parallel therapy along with the antibiotics and antifungals, because often there is a lot of dilemma whether we are dealing with infection or it's a kind of macrophage activation syndrome. Then, of course, we often use cyclosporin in most of the patients as IL-1 is not available with us. And then in a couple of patients, we have used rituximab or etoposide. So giving with this brief data set, I will take you through few cases which we have managed and the problems that I would like to bring to this house for discussion. So here is a 7-year-old boy who presented with systemic GIA since March 2018 and presented acutely with a fever, febrile episode of 7 days with chest pain, rash, and an examination he was tachypnic, along with there is a pericardial effusion. And there is, as we can see, there is a consolidation in the left lower lobe. And this is the trend. When the child was admitted, he had the high count, the ferritin was high, and he was tachypnic to begin with fever and arthralgia. We started a bit of, because there was a consolidation at presentation, we thought there is an infection, and we started antibiotics, such those are the steroids. Down the line, he started deteriorating, and we can see that the ferritin shooted up to more than 1 lakh, and the platelet and the counts again dipped down, and he has frank shock and meeting all class criteria for macrophage activation syndrome, following which he was started on IV methylprednisolone, IVIG, and we started on cyclosporin as well. In this boy, we gave tocilizumab, and after giving that, there was an improvement in clinical parameters as well in the lab parameters. So, I mean, and one thing that I want to, probably we were discussing yesterday, that the counts often become erratic. I mean, rather than just penias, they often they are throwing 29,000, 40,000 of the total counts with some atypical lymphocytes, which at times come in the peripheral smear. I would like to have an opinion from the house on this particular picture. That's one key message and this point of discussion I want to bring from this case. Then the second thing, probably thoughts on the interleukin-6 inhibitor as a treatment modality for macrophage activation syndrome, where settings like anakinra is not available like in ours. Because there is some evidence that IL-6 data where IL-6 predisposes to MAS also has been published, but not there. Now, coming to the next case, this is a 14-year-old girl who's symptomatic for last 10 years, anemia, hepatosplenomegaly, DCT positive, asymptomatic for last 4 years, and then again had the classic features of lupus, diagnosed as lupus, and then presented to us. So when she presented to us, we can see that there is respiratory distress, fever. She was initially hemodynamically stable, but over the time she has also a CMV pneumonitis, fungal infection, and diffuse alveolar hemorrhage. And again, down the line on day 3 or day 4 of the illness, she has again the ferritin shooted up to 1 lakh with a compromise in the respiratory distress and the hemodynamic compromise. So again, we started on IV methylprednisolone, IVIG, and prior to that, we already started on antifungal and the management for CMV pneumonitis. Subsequently, what happened is, despite all our efforts, she went into ventilator, and because we already exhausted with IVMP, IVIG, we started cyclosporin. Then we tried Plex in this girl, but unfortunately, she succumbed to the severe complication of macrophage activation syndrome. So the point here I want to bring is a thought for the opinion about the Plex in macrophage activation syndrome, particularly in settings like ours. And then again, to begin with, we had seen that we are struggling with lots of infection in this girl. So is there really a biomarker like IL-18 which can really differentiate between acute infection vis-a-vis macrophage activation syndrome to make the clinicians more confident in starting the immunomodulation? So here is the next case. She's a 2-year-old girl with Down syndrome and presented with fever and rash somewhere back in April 23. To begin with, she had joint swelling and then has subsequently was probably labeled as MISC to begin with, given a shot of steroids and IVIG, did well, but later on again she had bicytopenia, raised ferritin to the tune of 90,000, and then lymphadenopathy and raised CRP. So again, a possibility of secondary HLH lymphoma were done. Extensive workup was being done. EBV serology was negative. The bone marrow aspiration was again negative. And there was no evidence of malignancy. And keeping a possibility that she was a Down syndrome, and with such high ferritin levels, a possibility of primary HLH was also considered. And a clinical exome was not in keeping with that. So she remained asymptomatic for some time with steroids and cyclosporin, and down the line, again, she presented with fever, recurrent episodes of requiring blood transfusion, anemia, and very high ferritin. And again, steroids, cyclosporin, and JAK inhibitors were started, but probably the disease was not controlled, and she was lingering on with fever, or what we discussed in the morning, smoldering mass kind of picture. Down the line, when she presented to us, she was having respiratory distress, was also put on mechanical ventilation, has pulmonary hemorrhage, and of course has ventilator-acquired pneumonia, Klebsiella, and again the ferritin was more than 1 lakh, and she was not really doing great. And this is the CT scan we did. We thought that this is Down syndrome with systemic onset JIA because of the clinical lab parameters, thought that this is ILD, but actually this was not ILD, this was just the infection and consolidation in the, probably because of the Down syndrome, she was having recurrent aspirations rather than ILD-like picture. So the challenges here were the systemic onset GIA with recurrent mass. So what we did in this girl was etoposide. A low dose of etoposide was given, and then she was put on biweekly tocilizumab. And at the last follow-up, she's doing well on biweekly tocilizumab, and she's just on 2.5 mg once a day of steroids on this. And we had to just give a single dose of etoposide in this girl. The respiratory distress oxygen dependency was not because of ILD, but because of the aspiration pneumonitis, which has settled down, and off late, she is off any oxygen. So again, as we have discussed in the morning, that trisomy 21, probably because of the homing of interferon genes in chromosome 21, might be responsible for predisposing these children for maybe recurrent mass. So the thought again from this particular case is the use of etoposide and JAK inhibitors in children with macrophage activation syndrome, because these are the drugs which are available with us. So to summarize all these cases in my presentation, I want thoughts from the house and discussion on the erratic total leukocyte count that we have seen the case 1 and few other cases to in mass rather than absolute leukopenias. Second is again the need of a biomarker like IL-18, which can really differentiate between infection versus mass, and then probably trisomy 21, systemic GIE and macrophage activation syndrome, and thoughts on the therapeutics like IL-6, etoposide or JAK inhibitors, which are available in our settings in contrast to anakinra, which is freely available here. Thank you so much.
Hello, good afternoon. It's a pleasure to be here, and I'm glad to participate in such an important meeting. And thank you that I can have the opportunity to present this challenge and refractory systemic GIA, not refractory, difficult to treat GIA. And it's really a great emotion to be here with all the parents and mothers that have witnessed their cases and help to support all the children all over the world. And I have Luciana Peixoto, one of our volunteers that help a lot in our NGO that we have at the Federal University of São Paulo. So I am the head of the pediatric rheumatology in the Unifesp, and Jade is my assistant at the Federal University. So this is Luma, a girl that now she is 8 years old, and whose diagnosis of systemic GIA was at the age of 4 years old with typical features. So fever, rashes, arthritis, anemia, thrombocytosis. In order to save time, I put a timeline. So in the beginning of 2021, she was treated, so was the diagnosis, and then she began to receive cyclosporine, and 5 months later, we associated tocilizumab. So she had then the combined therapy, cyclosporine and tocilizumab. Because of intolerance of cyclosporine, we have to suspend this drug. And then tocilizumab was also suspended due to an anaphylactic shock on the 3rd infusion. So then methotrexate was initiated, and in October 2021, we added adalimumab because the main symptoms were arthritis and not the systemic features, systemic manifestations. In the 1 year after, she was on adalimumab that had to be suspended due to secondary failure. So she was doing well, but then was a secondary failure. And then we had to suspend methotrexate also due to intolerance. In June, due to a judicial process, so it's the same as in India, we don't have the anti-IL-1 drugs, neither canakinumab nor anakinra, so but we got it, and in June, so 1.5 years after the diagnosis, she began to receive canakinumab, and then we combined it with associated leflunomide. In January 2023, leflunomide was suspended due to gastrointestinal symptoms, and for the first time, she developed a macrophage activation syndrome that was treated with pulse therapy and cyclosporine. In July, canakinumab had to be suspended due to difficulty in sourcing and also because she still maintained persistence of systemic symptoms. She returned to leflunomide that was associated to tofacitinib, again with a judicial process at the end of 2023. So in March 2024, she presented the second macrophage activation syndrome that was treated with a 5-EIG, pulse therapy, and cyclosporine. I have to emphasize that all throughout this time, since 2020, she's on corticosteroids. Sometimes we could taper, sometimes we had to increase several pulse therapies. A lung screening, active lung screening was negative, so she has no lung involvement. Now, currently, she is active with maintaining joint activity using tofacitinib and leflunomide with 17 active joints and some episodes of systemic activity, always after viral infections. The labs are mild anemia, so the current lab values, mild anemia, mild leukocytosis, a mild increase of platelets, high erythrocyte sedimentation rate, and also CRP, and fibrinogen. And then I put some potential alternatives to discuss with you in order to help us or to have a clue. A different anti-JAK agent, so she's on tofacitinib, and as I said, she's still active. She has some up and downs, but is still active. Another attempt at desensitization to tocilizumab, I didn't tell you, but we tried to, after this anaphylactic shock, we tried to do the desensitization, but it didn't work. So maybe you could do this with the allergists. Association with abatacept, so maybe tofacitinib and abatacept, or what else? So we are in Brazil, so we take part in a lot of studies with anti-JAK, clinical international studies, but we don't have available other drugs. Thank you so much. I hope you could understand me.
Our next presenter is actually going to present by video. Dr. Juan Manuel Mosquera, I hope I said it right, his flight got delayed and he was not able to make it. But he has recorded a video sitting in an airport, and I think our team has, do we have it? No? Not yet? Okay, we don't have it yet. So maybe we can start with the speaker after that. What? Okay. Dr. Caifeng Li, or did I say that? I hope I said that right. If not, please correct me. We'll bring up your slides. Yeah, okay.
Hi, everyone. This is my great pleasure to be here to talk with something about the systemic GI and mass in China. Because the time limit, so I just give a briefly introduce. So is it okay? My slide there.
Yeah, it's going to take a minute.
Okay, okay.
Yeah.
Thank you. We have a lot of data. Yeah, this is I'm Caifeng Li from Beijing Children's Hospital, China, Beijing, China. This is my topic. So this is about something I will talk. In treatment, we use usually for systemic onset GI use a lot of chemical therapy. It's not just like biological. So steroid inside and cyclosporine, thalidomide, but and also tocilizumab JAK inhibitor. We don't have IL-1 inhibitor, and also we don't have like a canakinumab and Kindra, etc. So and also we have the plan is like the give generally we use the steroid with plus inside. Usually we give cyclosporine and sometimes we use thalidomide for activity systemic GIA, and also we for the difficult to treat patient use tocilizumab. And for refractory systemic GIA, we combine some chemical therapy with tocilizumab or maybe JAK inhibitor. And for some people, they are just current for the arthritis, not for inflammatory. We use the TNF inhibitor for treat arthritis. This is some dates from our research. This is 54600 systemic GIA in the beginning. This is just from our central. We have a lot of data from the multi-center in China, but it's very difficult, complex, so I didn't have time to analyze that data. For this data, we used almost 100% patient. We use steroid in the beginning. Because this is inflammation is very high, we use the steroid, but not so long. And also we have used cyclosporine and inside the tocilizumab, like this is some percent here. And almost people in the beginning, we plus steroid plus cyclosporine. And this is the later used medication. Thalidomide is for us is very cheap and work very well. It is for the and also cannot induce some infection, so it's a good drug for us for control the inflammation. Then this is some data for the follow-up dates. This is 260 GIA. We treat in the beginning use that, and if the patient hard to treat, we plus biologic or maybe JAK inhibitor. This is for 1 month, 3 months, and 24 months follow-up. This is efficacy. Almost people get ACRP response, like 70% get 75% response. This is some data from the follow-up. This is some data from mass. Systemic GI with mass, we have this some research, another research about 141 systemic GI with mass. This is some 94 males, and our patient is maybe more than girls for mass. I don't know, but in the other countries not like this. I don't know the reason. And also this is the onside. The children when they are for 3 is maybe 5 years old. So the 11% cases when they onside, when they came to the hospital, is just with mass. So this is a very severe patient. For the clinical manifestations, they have a table here. So they have a very typical systemic GIA activity, systemic GIA. Also, almost patient, they have liver function damage, and also some have a nervous system involvement, especially for the respiratory system involvement. They are, some of them may be very severe, like ARDS, and also some other organ involvement. This is very common. So they are very severe patient. We treat mass use, first of all, we use pulse steroid. This is because that in that time is a cytokine storm. So I think the the powerful anti-inflammatory drug is steroid, not just only one cytokines. So because the many cytokines just elevate very like storm, so we need a treatment very fast and very powerful. So we use the pulse steroid, and then we usually use cyclosporine and also some other IgG, some others. This is like we combine with the different medication, but we don't use the like we only have tocilizumab. We don't use tocilizumab in a very high storm, cytokine storm. In that time, it's hard to, if you use tocilizumab, maybe you get the mass very severe. So we don't use that at that time. So we use them before the mass. In the beginning, the activity is systemic GIA. This about lung involvement. We have 28 systemic GIA, including 38. The lung disease is 38, like 13% of patients have the lung disease. So this is some data for the lung disease. The lung disease is almost like interstitial lung disease. And also they have, this is some picture for image for the lung damage and also some different subtype. We treat them, use steroid, and also in the beginning we use like 2 or 3 circles pulses. And also we use cyclosporine, and sometimes maybe we use the cytoxin. And we also use JAK inhibitor and some others, and also somebody they have like plasma exchange. And for the heart treat, we but with mass, even with mass, we use the etoposide. This is treat the patient. Some is very severe, get like pulmonary hemorrhage, and this sometimes maybe like respiratory failure. Some very severe ARDS. This is the patient image. For the heart treated SGIA, this is 11 cases the date. This date, 5 are with a recurrent mass, 5 for the pulmonary involvement. So this is some data we use like a different regimen to treat the different situation. But the hard thing is when you use many medication, get the infection. So the reason for diet is because of the infection. So this is something we need to consider. If the treat more earlier, maybe the inflammation is so high, and also the drug is not so much, so maybe you can control the disease. If in the later recurrent, the medication you use a lot, and also can cause infection, is a big problem. So this is briefly I introduced something, but now we just do something for we get some little bit of money for foundation. So we do something for registration. With first plan, we want to do registration for 1,000 patients. In this end of this year, maybe we finish this plan. So also we want to do something, but now we just research for like some cytokine like IL-18, but not for everybody check that because it is very expensive. So when we diagnose systemic GI, and also we found somebody have a mass, we check the WBC, we check the stage rate is decreased, and the ferritin also we check like liver function, some like chemical, and found some hints, found the early onset mass. If treat the mass more early, maybe more effective, more good response. So this is a different situation. So we don't have a lot of biologics. So we treat them like chemicals more and compare with the different chemical to treat the patient. in my opinion, because systemic GI is like the inflammation disease, inflammatory disease, so the control the inflammation is very important. So I think even no steroids, no control. So we just want to, as possible, to decrease the steroid. We don't use a big steroid, but we need to early control the inflammation. This is our experience. Thank you very much. Okay, thank you.
Dr. Bagri.
So I think we have a few minutes for discussion and questions, and I think the questions, it looks like it's going to go both ways, right?
I think you had raised some questions.
Yeah, so can we maybe go back to your slide and, because you posed, yes, a few questions specifically, so we can look at them and maybe some people in the audience might have suggestions. So I think your first question was about the use of biomarkers to distinguish MAS versus infection. And my understanding that the list of infections that you are dealing with in India is probably different from what we have in Cincinnati. And dengue fever probably will be a very important one, correct?
Yeah, but dengue is the seasonal problem. I mean, usually it's not perennial. I mean, mainly during seasonal. But apart from dengue, the bacterial infections again, because as the cases I showed, they were not having dengue, they were mainly having pneumonia.
What about Leishmania? Leishmania can give you...
Leishmania again is not common in the entire India. It's only in the eastern part, that's known as state known as Bihar, and that otherwise it's not common.
So let's assume that the infections that you are dealing with are not terribly different from what we deal with. So from the audience, can I ask the audience, what would you use in a setting like that? What biomarkers would you use to distinguish MAS?
I will reflect the questions.
I think it works. I don't have. I come from the Netherlands, so we don't have the same infections like you have in India. But at least we have some experience with bacterial infections, and in most of those cases, so streptococcal pneumonia or staphylococcal infections, IL-18 is rather low. The only infection that I've seen with really increased levels of IL-18 compatible in the range of severe systemic GIA or MAS is leishmaniasis.
What about S100 proteins? There are lots of fans of S100 proteins. And, yes, go ahead, please.
I mean, that's a difficult. It's not easy to differentiate wherever you are, infection, and you can have both. Most of the time, we assume that there might be an infection and you're also flaring. So generally, we end up treating both.
Yeah, and I think apart from the biomarkers that we are talking about, S100 or calprotectin versus IL-18, the ferritin itself, again, we see that it is often raised in some of the infections, and particularly dengue, it can shoot up to more than 10,000 or so. So that again gives a bit of problem.
Yeah, I honestly, the answer to the question is I don't think there is a single biomarker that will help you. I think you need to look at the patterns. And I think Scott yesterday showed a very nice panel of biomarkers that we would use certainly in Cincinnati when we have to deal with this kind of question. But
I think it's worth pointing out that, like, if the IL-18 is high, it doesn't mean they don't have strep or dengue or, you know, so I think it's a specific biomarker and especially, you know, diagnostically helpful for saying this patient has stills. But if it's a flare or even if it's a new patient, you still want to look for modifiable infectious triggers.
And Paul, since you're a skeptic of the IL-18 story, so what would be your approach?
Well, very much like, yeah, you can have this.
Very much what the approach that Fatima took.
these are often infectious triggers, and it's the host response. So for me, it seems quite clear that if after a bit of time on antibiotics, usually you push the steroid up a bit, you watch them for a bit, you get a sense very quickly that this may be evolving into hyperferritinemic inflammation. So even if there's infection there, which there probably is for many patients, you treat the host response and any modifiable infection. So treat both.
Yeah, I very much agree with that. I think in this scenario, the patient is more likely to die from hyperinflammation rather than infection itself. So whether there is infection or not, you need to address hyperinflammation, but treat the infection at the same time. So I think Pat got it right. Your second question was about the erratic behavior of leukocytes in MAS. Any comments on that, Fabrizio? Yeah.
I think we have seen a number of patients. I think we've seen a number of patients with elevated levels of elevated leukocyte count. They might have neutropenia. This is particularly true in secondary HLH infections, more than in classical MAS in the context of STIs. So it's, you've seen. Regarding the atypical activated usually works. No, I made a big difference. That didn't make a big difference.
Yeah, thank you. So we've seen patients with high leukocyte count, particularly in context of secondary HLH rather than MAS. The other comment I would say about the atypical lymphocyte you mentioned, I think those are activated T cells. We have, there are papers proving this. I think this is pretty much standard, I would say, in hyperinflammation, so you would see that. I have no other
my
comment.
personal view, it's very difficult to interpret the behavior of white blood cell counts because you have different forces driving them in different directions, right? The underlying disease drives them up, MAS drives them down, the infection is possibly driving them up. Then we also have steroids that would, make us release leukocytes in the peripheral circulation. So too many forces driving that count in opposite directions. And honestly, I don't pay that much attention to the leukocyte count. It's very difficult to interpret.
I was going to say the same thing. I think depends on even when you take the blood. Sometimes if you give steroids and take it out, and so timing is important. So it's not going to be easy. But typical lymphocytes activated T cells, or there might be an infection, ABV, those kind of things.
I think the question about the relationship between trisomy 21 and MAS is a good one. I think you pointed the right explanation for that. We do view patients with trisomy 21 as mild interferonopathy, exactly for the reasons that you described. And I think that component certainly synergizes with other interferon-driven pathways in MAS and make this disease even more difficult to handle in this group of patients. And I guess you also wanted to ask some questions about the therapeutics, correct?
Yeah.
So sorry, Fabrizio, but it's IL-6, so you've got to answer this question.
I'm not sure I understand the question. I was going to ask, actually, what do you mean by IL-6 predisposes to MAS? So there are data showing that high IL-6 predisposes to MAS.
So what I mean to say is that there are few case reports which suggest that the use of tocilizumab predisposes for macrophage activation syndrome, but there are anecdotal reports. I'm not much inclined toward that. But the key question is, can this be the first-line drug where settings where anakinra is not available?
In MAS?
Yes.
I don't think so. I mean, so I think I'm seeing Professor Shimizu nodding. So I don't think tocilizumab trigger MAS. Any perturbation in a patient with SGIA may trigger. We have seen MAS triggered by anakinra, which doesn't make any sense. It's obviously not the trigger. I mean, viral infection is a different story. So, and the old guys like us using penicillamine have seen MAS triggered by penicillamine in these patients. But anyway, I think the data are actually in the other direction. In the tocilizumab trial, the rate of MAS was lower than expected. So I think because you're controlling the disease and you're getting a lower chance to get into MAS. It doesn't mean that you can't get MAS. It means simply you're lowering one of the predisposing factors. Exactly.
I think the right way to see it is it does not provide a full protection
No,
against
no,
MAS.
it does not.
Yeah. Paul.
So there have been many patients where they're teetering and there's sort of smouldering MAS, and these are the ones with high IL-18. And we've definitely had several patients where we've, because we've got limited therapeutics, used tocilizumab, and there's a direct temporal relationship between giving the IL-6 blockade. And Professor Shimizu is also given a very plausible hypothesis in relation to the IL-18, IL-6 ratio, where sudden perturbations can tip you into MAS. It was already teetering, so it's the disease, and by the way, you've just helped it on its way in select patients with high IL-18, it seems. So these are small patient numbers, but clearly for the patients that I've looked after, I avoid tocilizumab when I'm thinking, actually, this is teetering on MAS. At least fill them up with steroid first before giving that to try and tip your balance in your favour.
And Paul, keep you the microphone. The next drug in line is etoposide, so you've got to answer this question.
Well, etoposide is a dirty drug, and you use it as, in my mind at least, as a bridge to transplantation when you cannot get hold of emapalumab. So in the UK, we're in the situation where we've been using emapalumab in the trial. Everyone hears about it, they get excited, they want it, and they can't get it. Usually it's a desperate patient on an intensive care unit. They reach out to SOBI, and SOBI are helpful, but it may take them a few days. And so you really have to do something. So for very sick patients, I have no problem at all with just dipping into the HLH, a modified HLH 2004 protocol, because the findings of the HLH 2004 actually differ from what we do as rheumatologists. They say, don't give cyclosporin, it really causes PRES. So they like dexamethasone and etoposide was the findings of the HLH 2004 study, whereas we, of course, fill them up with cyclosporin, dexamethasone, etoposide. But at that point, you're really saying game over, and we're going to start working out for allo-HSCT. Now, if there's a happy coincidence and things stabilise, great, then you've got them tissue typed and all the rest of it. The very fact of working them up for BMT doesn't mean to say you're going to need to have it. But as a general rule of thumb, if you're reaching for etoposide, you should be thinking about allo-HSCT further down the line.
Caifeng, you wanted to comment?
Yeah, I want to. So first one about the leukocyte decrease. If the patient in the beginning, if the disease is very activity should be very high. This is we know the knowledge. But in the beginning, it's just because it's systemic. I think clinical manifestation is very important. If infection caused the leukocyte higher, this is just very sick. The patient is just like not in activity. It's different, totally different manifestations. Clinical manifestations different with a lot of patients. But if the mass, the leukocyte is lower, this is we know that. So I think we need to pay more attention to clinical manifestations, not just cytokine. This is because I'm a clinician also. We are low, just every day for the many patients is different. For treat mass, the inflammation is very high, the high fever, rash is very sick, and if you don't use steroid, just give like tocilizumab, maybe get the mass so severe, and then maybe the blood pressure is down, and everything is just so bad. So we need to control the cytokine storm. So I think it's very important, very useful effects and immunology very control the inflammation. First of all, is steroid. You need to control every cytokine down and control the inflammation like blood cell, like edema, like everything. Just only give anti-IL-6 is not so work. Maybe even because it's so big a protein, maybe can cause macrophage more activity. This is my opinion. So yeah.
Thank you.
Okay, thank you.
I'm looking at the next drug in the list. Any fans of using JAK inhibitors in MAS?
just wanted to ask one question about the IL-6 blockers and MAS, and it's a way off the field question, is because we, at least here, we don't normally use those on patients who have MAS. But I think I saw a quote from Russia that they noticed that patients with MAS, when they use like tocilizumab, they had higher risk of anaphylaxis. Is this something that you notice in your cohort since you end up having to use IL-6? Do you notice that the MAS patients who get toci, they get more anaphylaxis?
You mean for IL-6? Yeah, we use that if the activity systemic GI, we use that in the beginning. Not for everything's like bad, like a can cause mass, not like the inflammation showing in the top. We don't like use that. We use earlier maybe controlled mass. We use tocilizumab to decrease the steroid. Somebody is very severe, very high fever. We use that maybe because that's the very severe patient.
I actually follow up on that to Fabrizio, Paul, or whoever knows. So someone is on IL-6 therapy and IL-6 for their systemic and they have an MAS. Would you stop the IL-6 at that time or do you continue? Because for anakinra, we say you need to continue your systemic GI therapy. Would you do the same with tocilizumab or do you add steroids for sure before you do?
I would certainly add the steroids. No. Continuing tocilizumab is in the trials was not allowed. You had to stop tocilizumab in the trials. I don't agree with Paul, to tell you the truth. I'm not sure I understand why you should go into the IL-18 high producer. I think there is very little evidence that inhibiting IL-6 favors IL-18. I don't think it's a balance. I disagree. For those people online, he's mimicking a balance, but it's not a balance. I don't think it's a balance. It's a very difficult question to address. I think I would focus on MAS because that's the urgent need. Whether you wait 1 week or 2 weeks to restart tocilizumab won't make a difference. If these patients are on chronic tocilizumab, they are at steady states, you don't get rid of the drug. No.
The same approach in Cincinnati. We're running out of time. Yes. Rashmi is making an angry face. So JAK inhibitors, to make it short, please raise your hands, those who would use JAK inhibitors for MAS. Well, there are lots of fans. I'm not a fan of JAK inhibitors because I have too. Yeah, certainly. Well, good question. But I probably have seen patients developing MAS on tofacitinib, ruxolitinib, and baricitinib as well. So I've seen MAS on the treatment.
But you can see MAS on anything.
Yeah, true. But all right, I think we're good.
Yes, thank you so much.